that you have conformed to those standards. So I want to end by talking about a final section in the report, which talks about a national labor force strategy. The Romano report on the future of healthcare in Canada, the Hall report many years ago that led to the establishment of the coverage for doctor care in Canada. A number of other reports have called for a national labor force strategy, and we don't have one. And the ILO, the International Labor Organization, the World Health Organization, and various other international bodies have said that there is a crisis in the labor force for long-term care long before COVID happened. And of course, now that there's a crisis in the crisis in terms of long-term care. And in terms of establishing that labor force strategy, we would argue that there should be 5 standards. First, they all involve recognizing. We have to recognize that this is skilled work. And that means that you don't start handing the work to people who have no formal education and training for the job. Second, that the conditions of work are the conditions of care, that you have to have both if you're going to provide decent care. We have to understand that care is a relationship. That too has implications for the conditions of work. We also have to understand, and this is the 4th of the 5, that all the people who work in a home are part of the care team. And that too implies that you don't contract out the work. And 5th, that these standards have to be enforced, and that's part of the essential nature of this labor force strategy. So I'm happy to expand on any of these principles, or to talk about the other foundational principles we talked about in terms of moving to a continuing care strategy, but I'd really like to hear from you and from the other 2 speakers. Thank you.
Thanks so much, Pat. I'm going to turn it over to Chris.
Yeah, so Chris Parsons with the Nova Scotia Health Coalition. And I guess one thing I'd start with is something that I forgot to add to the biography specifically for this, which is while in university, I worked in dietary at Northwood in the Manor. And I think that has a lot of my thoughts about long-term care are informed by that experience of being on the front lines of it. And I think that when Pat talks about both the fact that it is skilled work, but also that it is work that is dependent on everyone that works in the facility, I experienced that firsthand and sort of remain decades later, unfortunately decades later now, in awe of the work that people I worked with did day in, day out, sometimes sort of decades on end, and how difficult and skilled it is. And that I can sort of say unequivocally, I worked dietary in a pretty entry-level position there. It was the hardest work I've ever done in my life. And that was decades ago. And the situation has only gotten more difficult since then. The other thing I just want to quickly say about Dr. Armstrong's work is that I think that what's really important, one of the really important things about her ongoing work and the work of her team has been the fact that it is both sort of rooted in principles. And I think that these proposed sort of national standards start from principles at the beginning of the document, which I think are very useful, but also is derived out from a pretty deep collection of evidence based on international experiences in long-term care. So I do encourage folks to look at some of the wider work that Pat and her team have done. But the first thing I really want to talk about is some of the unique characteristics of Nova Scotia and long-term care in the province. And I think those inform as well why standards in long-term care that are national are important for Nova Scotia in particular. So I know there are some people from across the country. I saw Sandra, my colleague from Alberta, and so I know there's other folks from elsewhere in Atlantic Canada. But I think that the context matters in each province. I think that's an important thing to think about. But I think that long-term care standards that are national are important regardless of where we are. So first of all, I think one of the things that doesn't make Nova Scotia unique is that long-term care was in crisis before COVID, and it's only gotten worse since COVID started. So in Nova Scotia, there's been 65 deaths from COVID-19, and 56 of them were in long-term care in 3 facilities concentrated mostly, again, in Northwood, Manor, and the center, or Northwood as a whole facility in Halifax. That means 86% of the deaths in Nova Scotia were connected to long-term care facilities. The national numbers are very similar. It's 78% of deaths in Canada have been connected to outbreaks in long-term care. Those numbers were put together by a friend of mine, actually, Nora Loretto, whose sort of tireless work of keeping that updated has been really helpful for, I think, for us to understand what's been happening. So those are deaths in long-term care facilities, which we also need to think of as deaths in communities. There are also deaths in workplaces, and those things all sort of intersect. That it has been a case where this is a disease that has struck vulnerable people and it's struck working people. But the crisis in long-term care has been hard on working people, and it's been hard on vulnerable people. It's been hard on people who have been who are older. It's also been difficult on people who are living with disabilities and need to receive care in these facilities as well. So even prior to COVID-19, Nova Scotia has seen long wait times, chronic underfunding, chronic understaffing, and that's led to a constant state of crisis. And it really is a testament to the resilience of staff and residents and families that the system has functioned at all, given its sort of under-resourcing. And that the quality of care, despite all of these challenges, is oftentimes the way that individuals experience it. It can often be quite good. It can often be quite rewarding for people who live in long-term care, but it's not sustainable. We can't continue down this path for a decade. What we actually heard the Deputy Minister of Health say at the first Health Committee meeting back after the legislature decided to take 4 or 5 months off from doing any work in Nova Scotia, the Deputy Minister said before the Health Committee that we could have gone another decade without anyone noticing there's anything wrong in the long-term care system if we weren't hit by a once-in-a-generation pandemic, right? Which is a patently absurd statement. And it's an absurd statement coming from someone who is, up until recently, was a practicing doctor. In 2019, the province convened an expert panel that made recommendations to deal with a number of deaths in long-term care, including death of Bob's mother-in-law was one of the, I think, the deaths that really spurred on the need for that panel. The recommendations were, some were good, but they weren't complete, and they haven't been fully followed through on. And so I think that this is something that's been ongoing. Nova Scotia, like many provinces, has a highly rural population, particularly the aging population, and the demographics are extremely uneven. And I think that is one thing we need to think about in this province is that living in Dartmouth or Halifax, it's easy sometimes for people like me to lose sight of the fact that this crisis looks very different, the crisis in long-term care, in other parts of the province, particularly rural parts of the province where families tend to be leaving, where you don't have, so the informal care networks are stretched very thin in rural Nova Scotia, and that there's been really uneven economic development throughout Nova Scotia's history, and that's only intensified over the last 10 to 15 years. So what we see is new immigrants, people migrating from elsewhere in the country, are moving to the major urban center, and in Nova Scotia's case, that's one place, which is Halifax. So we do need to think about ways in which this is also a rural problem and a problem of smaller towns, and that the demographic shifts we're seeing need to be kept in mind on that front. The one other thing that I think is really important to think about with Nova Scotia is that in Nova Scotia, only 14% of the long-term care homes are public. 41% are private and not-for-profit, and 45% are private for-profit. The Canadian average in Canada as a whole, 46% of the homes, of long-term care homes, are public. Only 23% are private not-for-profit, and 28% are private for-profit. So Nova Scotia's numbers in terms of that divide of those three groups, that is the publicly owned, the privately owned but not-for-profit, and the privately owned for-profit, our numbers are actually considerably different than what they look like across the country. Our public numbers in particular are the second lowest in the country. The only exception is New Brunswick, which has fully privatized its system and turned it over either to for-profit or not-for-profit. And we have, I believe, the largest number of our homes are not-for-profit, private. So that means that our system looks different. It means that the government has outsourced delivery. It also means that there is a large market for private interests to want to flood in now. There's room for growth if your interest is in making money off of warehousing seniors at the lowest possible cost, right? So I think that that's actually really important. And making sure that new money doesn't go to private facilities is particularly important here because of that potential for growth in that industry. But also the other thing that's really important is the coordination piece has really been missing in Nova Scotia. And I'll talk about that a bit more, is that we have a very fragmented system here, much more fragmented than even in other provinces. The other final thing is the state of public health care and long-term care in Nova Scotia is bad. We've had some success with public health measures of fighting COVID-19, but part of sort of the dark irony of that is that had we not been successful, I think we would have seen catastrophic results in Nova Scotia. The measures that people are feeling, including families who aren't able to visit loved ones in long-term care, as well as other limitations that we've seen, have been necessary. It's been good that they've been implemented, but the reason they're necessary is because we have a public healthcare system that could not accommodate even a slight spike in COVID-19 cases, and we saw what happened once it entered into one long-term care facility. It did damage very quickly and was very hard to deal with, and the system was incapable of responding quickly. The other things I'll touch on here in the last couple of minutes is just that why Nova Scotia needs these standards. One is this lack of coordination we have. We have a much more fragmented system than other places. We have not-for-profit long-term care facilities that exist often for historical reasons. They were built by communities, often labor unions or charitable organizations that were local. And we've seen throughout the pandemic, actually, very good examples of the lack of coordination between the Nova Scotia Health Authority, the Department of Health and Wellness, who are tasked with overseeing them, and these facilities. And oftentimes it's not the fault of the facilities themselves, but the fact that there's these additional layers of decision making. For example, in Nova Scotia, there was a very good plan to build COVID isolation units for long-term care to move patients out of those units or out of existing homes into those units to prevent spread. The Halifax isolation unit, which was supposed to be at Ocean View, which is on my side of the harbor, hasn't actually opened. And that's because of a lack of coordination, communication, and ability to recruit staff because we don't have coordination. So even when we come up with good plans to deal with real problems, we can't actually make those happen because we have such a fragmented system. Hopefully national standards would help actually bring some clarity to that, but also reduce some of that fragmentation. In addition, the system is incredibly opaque. There's a lack of transparency. That's true across healthcare in Nova Scotia. It's true across everything in Nova Scotia. And we need national standards that force these things into the public view. We need additional resources. Nova Scotia does not have the ability to generate resources in the same in terms of taxation in the same way that other provinces do. There is fiscal capacity here. Christine, I'm sure, can talk a great deal about what that might look like. But the reality is we do need more money from the federal government, and that money has to come with alongside things like transparency, coordination, and standards. There also has to be very clearly laid out what the responsibilities are of this provincial government, of future provincial governments in Nova Scotia, that they cannot pass the buck either to the long-term care facilities, which has become a very standard part of why they enjoy having this sort of fragmented system, is it's never Nova Scotia's government's fault. And we need to make it clear that it is actually the responsibility of this provincial government. However, national standards won't be enough alone. Right? What we need is a full national strategy, which Dr. Armstrong has talked about, as well as her colleagues, and has gone into detail about it, that includes additional resources and funding. We need real enforcement. And we've seen how difficult that enforcement has been, for example, with the Canada Health Act. So we don't need just voluntary reporting. We need clear benchmarks that are made public that allow people like us at the Nova Scotia Health Coalition, that allow people like the people who are on this call to hold the government to account, to hold facilities to account, and to hold the federal government to account, make sure that the public actually has the information we need to be involved in the sort of big picture decision making about our public healthcare system, including long-term care. And so that has to be public accountability. And really importantly, the labor development piece can't be seen as optional. None of this works without proper labor development in long-term care. What we've seen, for example, with what I mentioned with Ocean View Manor and the crisis there and the inability to recruit staff to staff a COVID isolation unit, is that quite frankly, it is hard work. It's hard to recruit people into long-term care. It's hard to retain them. It has extremely, extremely high injury rates. You're more likely to be injured as a CCA in long-term care or home care than you are if you're working in heavy resource extraction. The level of back injuries is shocking for people who work in long-term care and home care as CCAs. And quite frankly, it's a solvable problem. The licensing and training of people is part of a public education system, or ought to be. There are spots for it. We have people who are looking to work. What we need to do is actually provide the resources to make sure that they're properly paid, they're not overworked, that we're also thinking about things like benefits. We're ensuring that workers have access to childcare and other things that they need to actually enter into the workforce if they want to, and that they're properly remunerated for doing so. Finally, we need a wider shift towards addressing the social determinants of health, because right now we have people going to long-term care facilities who are already in a situation where they're entering much sicker than they ever have before. And the final thing that I will say, just to wrap it up, is I just want to quickly say that we can make it happen. There's a lot of people, particularly politicians, who are going to say that they don't want the federal government infringing on what has been provincial jurisdiction, which is healthcare. That is largely a red herring. We built a national healthcare system, and we did that because the federal government brought money to the table. What we need to do is we need the federal government, we need activists and practitioners and families to force the provinces to say, no, I don't want money for long-term care. I don't want to open new long-term care facilities. I would rather have people die in substandard long-term care rather than take money from the federal government, because our egos will be bruised as provinces if the federal government tries to tell us what to do. Force politicians to say that, and then we'll hold them accountable for saying that. But right now, they don't have to say that because there isn't enough pressure on them to do it. And I think that a report like this and the calls coming across the country are first steps to forcing politicians, forcing decision makers and bureaucrats to make those difficult decisions, and force them, quite frankly, to make the easy decision, which is to accept additional resources and national standards that we know will save lives and improve care. So I'll leave it at that.
Thanks so much, Chris. I'm going to turn it over to Bob and say, Bob, I did put a link into the Facebook group, the Families for Quality Elder Care, and to say, of course, I didn't include all of the rest of your life and all of your career. I did focus on your bio in terms of the work that you were doing tonight, but I noted that you currently have an alpaca farm. So thank you for joining us tonight and the work that you have done and are doing for families, and in particular, in Nova Scotia and in Cape Breton. But I'll turn it over to you.
Okay, thanks very much. I'm so appreciative of being here and being able to speak to everybody. And what's been said so far is so true. And I can add from some personal experiences as well. Not just the one thing, but I can tell you that alpacas have an antibody to COVID, which I think everybody should know. But it's a very tiny goes on a receptor, and it can actually stop the COVID-19 virus. So they're working on experiments with that, which is kind of interesting. But one of the concerns I have, and a lot of this has been covered through the talks that have been done so far, but I'm very concerned that the government has not been prepared for the baby boom or the boom that we have. The facilities are certainly not capable of handling what's coming, and they're getting to the point where, beds right now, they need 1,429, and if you looked at some of the statistics lately, it's gone up about 27% in the last 2 years, and it's going to continue to rise unless something is done about having more beds in the province, and nationally they're having the same problem. I'm very worried about that because, for one thing, they're not prepared. They weren't prepared for the pandemic because of some of those issues as well. They don't have the supplies that they would need. This has happened not only here, but all across the world even, that no one was prepared for a pandemic of this magnitude. The amount of PPE and so forth was lacking at the beginning, and Canada was very fortunate that the virus did not spread as fast through Canada as it did through the US or overseas and some of the other areas. So there's lots of concerns about that as well. Everyone has mentioned the fact that staffing is a major issue, and you have to hand it to the people that are working in these facilities, because they're overworked. They're putting in more time than they should, and I know from my son, who's a cardiologist, he's an EP cardiologist, that working too many hours at some point becomes too much of a strain on you for making good decisions. And I think a lot of that should be monitored a bit on how much hours and how many hours of people are working as staff members in different capacities, basically. And they should also be designated as to what they're supposed to be doing in those capacities. Because one of the things we found when my wife's father was in one of the facilities is that there was even conflict and contention between some of the different areas, because they were asked to do things that were not what was on their original resume, let's say. And that needs to be adjusted in many ways. So the federal government needs to come out with an actual strategy and plan for these workers that's consistent, and from the standpoint of getting the wages, a lot of equilibrium there, getting the benefits that they need, getting the time off that they need, and not going from facility to facility or so you have your full-time and your part-time, as Dr. Armstrong has in her report. You have to make sure that those people are situated in such a way that they're there for the people that are actually residents and start to learn about them, because one of the other important things that comes out of this is that at facilities, there's a lot of talk about whether they should be smaller or profit or nonprofit and all these different things. There needs to be a better standard as to what's really working for the people. And I don't think they really have gone out and looked at what models work as better than others for the elderly and those that are becoming more, that are aging, and what's really needed and at what stage should they be evaluated for that. Because I think that a lot of times we say 6 hours or 4 hours. I mean, these people, some people need 2 hours, some people need 8 hours. I mean, it obviously is very different depending on which person you're talking about. And then you've got the other issues of, does the person have dementia? Now, most people over 85 years old, I know from Jeannie Ferguson that almost everybody has some sort of dementia by the time they're in their late 80s. A lot of those people, the acuity going into these long-term care facilities creates a problem for the people that are actually taking care of these people, the caregivers and the families, to know what should be done and to make sure that they have the education that's needed in order to deal with the situations that they run into, which could be violence, it could be abusive language, it could be just loud voices, it could be a lot of different things. But putting and mixing some of those people inside with other people that are more normal, let's say, at some point, it becomes a real major problem for managing that particular ward in that particular facility. So some facilities have actually taken care of some of that, but there's also, from what I've been told, there's been a little bit more mixing lately of dementia patients with other patients, which creates a bigger problem. So I'd be very concerned about that, and the skill level has to be upgraded on many of these that are applying for these jobs in such a way that they're going through a certification process on a regular basis, is my opinion, because if they don't get certified each year because of the changing demographics and the changing environment, such as a pandemic coming or whatever else is out there, are they prepared for what needs to be done for infectious disease, or making sure that the rooms are cleaned properly, or the laundry is done properly, or the dietary areas are taken care of properly, and even whether the medicine is being directly taken care of that the doctor had prescribed. We've seen cases and heard of cases where the doctor writes a prescription and things are changed on them because the doctor couldn't be reached or whatever the other situation might be. So these are issues that we're very concerned with. My wife's father was put into a hospital for 2 weeks, walked into the hospital with a walker and never walked out again because they never turned him or never put any effort into what needed to be done for him, because of a couple of things. One was they didn't have enough staff and they were crowded in the hospital, but then they brought him back to the facility, the long-term care facility, and the same things take place because they're not aware. And in his case, he had bed sores. They weren't rotating him, they weren't moving him around, and then they strapped him into a wheelchair for 8 hours a day, thinking that that was the right thing to do, or not thinking it, but they didn't have the time to move him, or they didn't have the ability to get someone else to help them move them, or whatever it might be. So a lot of these things aren't thought out. There's so much complexity to any facility that's been mentioned. I mean, you have to have everybody, like you said, as a team, working together in such a way that they're able to do the things that are necessary to make these people have their dignity and respect that they need. And a lot of these people have lost it because even the people that are working there have lost their motivation to work. And part of that has been addressed by the fact that we need to get their wages in line with what they should be earning. We should have the benefits available to them. They should have a right to vacation time, sick time, or whatever is needed in order to better be in condition, basically, mentally and physically, to take care of the issues that they incur when they go into a facility. A lot of times, I think it's missed. And we personally have seen it. My wife and I have seen that, and we actually filed a case through the Protection for Peoples in Care Act, which a lot of people are not aware of. But we actually filed a case, and the facility was found guilty of not providing the kind of care that was needed. And had we not done that, I think the bed sore issue would have been even worse than it is today in many places. So we feel like that's some of the issues that became pretty prevalent when you were talking about the pandemic have been set aside in some ways, and that they're growing and may become even worse of a problem as you get a bigger population with the staff that right now it's hard to recruit. The places that are at the universities and so forth that are doing the training are trying to speed feed through, I call it speed feed, these people back into the system without the proper amount of training that they need. And I've heard through some things that I read in the last couple of days that they're kind of sidetracking some of the hours that are needed at each level. There's an awful lot to be, like I said, it's very complex, and I have 1 minute to kind of just say, kind of what Chris said, putting it all together with all of our teams and everything that we do. And we have another group called Nova Scotians for Long-Term Care Reform that we've even joined with some of the other members, or even union members and so forth, that we're trying to put together a coalition of people that will help out and take the effort and make the effort to go and get the changes needed as soon as possible, because I don't think we have a long time to wait right now with what's happening with population, pandemics, and all the other things that are going on in this world. It's very complex, and it's needed to be on a federal level with a lot of leadership, which has to come from the federal level and then pass down to the provinces, and that includes the funding. I didn't go into one other thing that's real quick, but the ventilation systems in these units that are older and so forth are a major issue. I've been in biosafety for a lot of years when I was with my own company. Biosafety at these companies, they're not looking at it from the perspective of what's really going on in the HVAC systems. There's a lot of viruses and bacteria that accumulate within their systems that is spread throughout the buildings, and they need to look at that. Anyway, thank you.
Thanks so much, Bob. Really appreciate that. And thanks everyone for your presentations this evening. We actually have some excellent questions, and we received a few questions before the webinar via email. So we're going to try and address a few of them. A couple of them actually were around private for-profit. And the question in the chat is, what is your view about private facilities in relationship to the care and well-being of the clients? And previous to the webinar, we got a similar question, but around obviously private for-profit and perhaps alternative structures like the cooperative structure or whatnot. But maybe I'll ask whoever would like to respond to that. Perhaps Pat, yes?
Before I respond to that, I would like to respond to something that, or clarify something in relation to the 4 hours of work that Bob picked up on. That's not intended as a formula for every person gets 4 hours of care. It's a way of determining overall staffing levels, and it's definitely about hours worked as well, not about hours paid, and they're often calculated as hours paid rather than hours worked. So you can do what you said in terms of some people might only need 3 hours and somebody else would need 5. So that is, I think, built into that way of seeing it. I should also say on the models question, I think you raise a really interesting point about which way we should go in terms of models. And we've been in homes in 6 countries. And we also just completed a study for the City of Toronto. It's 10 homes. And we were looking at models. And our conclusion out of the models is there isn't one perfect model. It really depends. And to go back to what Chris was saying about the demographics, for instance, in Halifax, it makes a difference, the demographics in Halifax versus in the Bay, you know, and so we have to, I think that we can learn from the models that are out there, but there isn't a magic solution. It depends, I would think we say. So go back to the question I was supposed to be talking about in terms of for-profit ownership. I think we need to change the question, like, why should we have for-profit ownership? The usual discussion, justification for for-profit is that it saves you money. Well, it doesn't save the government any money. Every kind of home gets the same amount of money. So that argument doesn't work. That they're more efficient. Well, what does efficient mean? We have no evidence that they provide a better care, Now, to go back again to what Chris said, some of them provide quite good care, some of the public ones, not so good care, but we have lots of research of indicating overall patterns of lower staffing levels, of more of the ulcers that Bob was talking about, of more transfers to hospitals, more deaths in a consistent pattern in long-term care. Again, it's not all of the homes, but there sure is a pattern. So why would you invest there when we have absolutely no evidence that there is a benefit in terms of quality to go to for-profit? The other arguments often made in terms of going to the market and having a for-profit enterprise is choice. Well, we don't have enough beds now, so the choice is really just not on the table when it comes to long-term care. So the notion that should be the choice, but some survey I saw here in Ontario, where we have lots of for-profits, that when people do have a choice, and you're allowed to list three, it's the municipal and not-for-profits that are at the top of the list, not the for-profits. So we have to ask, why would we have some of our public money going to make profit when there's absolutely no advantage to going that route? Now, the one advantage that a government might not like to tell you about is that it keeps it off this year's books in terms of the government finances. So they're paying more over the long term for the other aspects of the care, but they're not building a home and having to pay for it all this year in terms of their books. Well, change the way you do the books, I would say, because there aren't other advantages. So I took a long time to answer a question about for-profits, but
no, it's
why?
Great.
Why?
It's great because you actually started answering a couple other questions. One was, what can we learn from other countries? And I know you have a ton of research about that. But I think you also started answering questions around the context. So one of the, somebody who asked a question, Sri Moulay, I think is on the call, who's at MUN in Newfoundland, was asking about these standards. Yes, was asking about the situation of Newfoundland Labrador. And I'll just flag that we just released a report in Newfoundland Labrador saying, you know, stop the P3s, which is something that Newfoundland Labrador hadn't been doing before, but now have full on taken it on, including in long-term care. I'll put a link to our report, but maybe I'll turn it back over to you, Pat, if you wanted to add anything else around what can we learn from other countries, what might be different in terms of the context here. Sorry, I'll leave it there, and then there are a couple other questions.
I'll try and be fast so there's room for others to go back to where.
Sorry, Pat, there was a clarifying question. Did you mention 6 hours of minimum staffing levels?
Yes. There's a new paper out by Charlene Harrington that talks about how, yes, we should be talking about 6 hours instead of 4 hours. 4 hours was established as a minimum in US research almost 15 years ago now, when, as Chris was saying, the needs of residents were made less complex than they are. And it's just, Bob made a similar point. I wanted to go back to talk about something Chris raised right at the beginning. We have to stop contracting out the services within other long-term care homes, especially food and laundry. When we went to homes in every country, clothes were a priority for everybody who was a resident or who was a family member, and of course the laundry that goes with it. And food is absolutely central to life. It's the main event of the day, as well as being nutritional. And if you contract out and bring in, as I saw in Nova Scotia, actually, food that is prepared in a central location and then shipped into the home, where's the joy? You don't even smell the food cooking, and you know, it's gone. So we shouldn't do that. What do we learn from other countries? Again, we would learn that there isn't a single model. The 6 countries we were in were Norway, Sweden, Germany, the UK, the US, and in Canada. And in Canada, we were in Manitoba, Nova Scotia, BC, and Ontario. And when I say we would take a team of 12 to 14 people into a long-term care home over a week And we'd start before 7 in the morning and stay till midnight to observe and interview. So, and the books small books that you mentioned earlier, Christine, capture a lot of what we saw and call ideas worth sharing. And those books we hand out free. I can't get in the university to get them, but they can be downloaded from CCPA for free now. And I think that you'll see there's there are lots of good ideas there. And I'll say one more thing so that other people have a chance. But in terms of what I also saw in the chat was a comment about community. And I think that while there's no one perfect model, what we did see in other countries was, for instance, in Sweden, where every second floor in one home we were in was for students, for university students. So there were mixed generations in the building, and then there was a feeling that, you know, life happens, that you're not being segregated out into a separate place. And it can even happen in a big building that you don't feel segregated out. So I think we have to think more about that. And my absolutely favorite example is actually one from Norway, where the nursing home was physically part of a huge town complex that had the town swimming pool, the town cinema, a daycare center, a spa, a cafe, and even a climbing wall. Although I have to say, I never saw anyone from the nursing home on the climbing wall. I'll stop.
Okay, thanks, Pat. Yes, dare to dream. Thank you. I mean, that research is so critical as we think about what is possible, as we talk about just minimum standards tonight. But we do need to think about what that could look like. One of the questions is, and I'll ask our Nova Scotia panelists to jump in here, is what can groups in Nova Scotia do to champion the national standards at the provincial level? If you have ideas you want to share, I'll turn it over. Chris, do you want to take that one? And feel free to also build on any of the other questions.
Yeah, I guess I'll answer that one first. I think that I think one of the things partially because we had a meeting at the Health Coalition today discussing election 2021, maybe 2 elections in 2021. One of the things that I think is really striking is we had a healthcare election in 2017. That was provincially. That was supposed to be the election was supposed to be all about healthcare. Nothing's better in healthcare, right? I think that so part of it is that we need to, I think, hold politicians responsible for that, including local politicians. I also think that we need to hold federal politicians responsible for that. And I think that we need to not let decision makers, be they politicians or bureaucrats, off easy on this, right? This province wants to cry poor when it comes to healthcare. We were the second province, a day after Newfoundland, who in 2016 signed a bilateral agreement, which cost this province $1 billion over a 10-year period in healthcare funding that we needed. The finance minister who signed that deal was Randy Delory, who then became health minister and said there was no money when he was health minister. And now he's running for leadership of the Liberal Party, which would make him de facto premier, and has all these great ideas for healthcare. At a certain point, it's just like either you have no relevant experience in healthcare, or you're responsible for those decisions in healthcare. It's one or the other. And I think we need to hold all politicians responsible for that across all parties. And I think that we need to agitate outside of elections for that, right? I think part of that has to be continuing to build strong community organizations that are particularly local community organizations that can put pressure on politicians and decision makers, as well as I think strengthening obviously organized labor, as well as like provincial organizations like the one I work for. So I think that there are ways to do it. I think that it comes with I think really trying to force politicians to make decisions. I think one thing that politicians and bureaucrats in this province have been really good at is simply not making decisions, letting things pass, not being responsible for them, and not having to decide one way or the other, and then evading any responsibility for those decisions. The only other thing I'd say about, I guess 2 comments about previous questions. One is in terms of what can we learn from other countries? I think one of the things that from Pat Armstrong's work that shows is that there's all kinds of innovative things that can happen that don't have to happen in the private sphere. There's an argument in private healthcare that the only way you can come up with new things is to let there be a profit motive involved. What I think Dr. Armstrong and her team's research has shown, and what I think we've seen throughout actually the pandemic, is that the public and not-for-profit systems can come up with new ideas if they're given the opportunity to do so, that there are intelligent practitioners and researchers in the public and not-for-profit system that can come up with new, better ways of doing delivery, and that there's no reason why we have to force one-size-fits-all on every resident or every practitioner or every facility, but that having multiple options doesn't require privatization to do it. We've seen it with things like the pop-up testing that was practitioner-driven. We've seen things with the speed with which people have responded all across the system to COVID without looking to get rich doing so. So I think we can expand that. In terms of the Newfoundland thing, I would just quickly say Newfoundland has all kinds of its own problems. I would say that as behind me, there's a map of Newfoundland. My wife is a Newfoundlander. My grandfather grew up in an outport, which no longer exists, Rencounter West, as they called it. Newfoundland actually is also an example of particularly sort of with mixed results, the mid-20th century fact that the state actually said it could do things. They relocated entire towns. They built highway systems in Newfoundland in an attempt to modernize it. There was once a belief in this country that, again, with mixed results in some cases, that the federal government could institute these huge programs and spend money to do them with the goal of improving people's lives. And in the case of Newfoundland in particular, people were promised better lives when they gave up their previous lives when we relocated in entire communities. And now those people's children are in places like St. John's or in places like Carbonear, these places that they were relocated to and told that they can't get the care they need in those communities, even though they were promised them when they gave up an entire way of life and in fact joined Confederation. I think there's a promise there, but I also think that there was an example there of why can't long-term care be the kind of massive federal project that we've seen when we built highway systems, when we built railroads, when we had massive systems of modernization throughout the 20th century to build like a modern Canadian state. And we've just sort of given up on that in 2021. And we've said the best we can hope for is that things will slowly get worse or you can buy it on the open market. And neither one of those things are working. I think we, in some ways, need to step back to a very imperfect 20th century projects of, I think, large state building. And that can work with all kinds of things, including childcare, including jobs programs. There's lots of things here. And we shouldn't be content with what we've gotten in the last several decades.
Hear, hear, Chris, and that all happens to be green too. So yes. Bob, did you want to add anything in terms of, I know you mentioned the Nova Scotia, long-term care reform group that's getting off the ground. Anything that you want to add in terms of what we can do to push these standards locally in Nova Scotia? Oh, you're on mute there. No. There
Sorry.
you are.
There we are. We started this group, I think it's now been about 4 months that we've been trying to work with the unions and also the coalition Chris is involved with and others to be an advocate for the people, to show basically that this is not just a small issue that they can avoid to address during the elections and whatever else is starting to happen over the next 6 months to a year, and that action needs to be taken from our group basically to push a little bit at the government to start making the changes that we're all talking about. Because at the end of the day, if we don't do that, we're kind of going into a pit, I think, where it's going to be harder and harder to get out of it if we don't start addressing some of these issues. And the pandemic is kind of put a little umbrella over things that's kind of sideswiped everything else that's been going on, that's been systemic for so many years, that I think we need to go back to the basics of what needs to be done. I mean, there's a lot of issues that in the complexity of things. I mean, I keep thinking that, why can't money be given to people to start opening up facilities? I know they're difficult to open, but if there's training and there's money available, why can't the funding get out there? Why can't there be more transparency? Why can't there be more especially accountability for everything that's going on? So if the government does put rules out there, I mean, it can't be just putting rules out there without a plan behind it to make sure that they're enforceable and there's compliance to them. And I think that's one of the issues that we've been seeing out in our area, is that the compliance to these issues is lacking at many places. Some of them are better than others for sure, but there's certainly more that can be done to make this more of a standard and bring that basically to the forefront so that we can talk about things that are on the same level and have strategies that may be different from demographic or whatever it might be, or from facility to facility, but working together, we can come up with a better plan for each place that would make more sense for what's going on in that particular area. So I think there's a lot that can be said for, getting together as a coalition and pushing that. And Families for Quality Elder Care has been an advocacy group for years now, and from what I can see, it's worked in many cases. But we also we're not enough strength to make any difference.
Thanks, Bob. So we need to build some solidarity there and continue that work. Appreciate that. I do see that we are at 7:30. I would like to ask, one of the questions that came to me before via email was from Ian Johnson and Olga Milosevic, and it is around the federal government signaling that they are indeed wanting to work with the provinces and territories to set new national standards for long-term care. They said so in, I think, the recent update, economic fiscal update. Do we know anything more? Do you have any inside knowledge? Are they knocking on your door and asking you for standards? What can we, do we know anything? Has anybody heard? Are the unions being involved? What will it take to kind of get this moving on the federal front in particular? Anybody?
Looked like Chris was going to say something.
Yeah.
I just quickly, the premiers met with the Prime Minister via Zoom, much like us here today, on Friday to discuss health transfer payments and whether or not there'd be strings attached. We don't know the results of that meeting. Stephen McNeil has said when asked during COVID briefings that he would be open to accepting strings attached to money as long as money flowed with it. That is him being pinned down more than he has in the past. Again, I think that we've done more complicated things than bring in national standards for long-term care. The key is to have money attached with it. My understanding is there hasn't been widespread consultation in any form on what those standards would look like. And I actually think that that's something we need to be careful about, is that it can't just be any standards. It has to be standards similar to the ones that Pat and her co-author laid out, which are ones that are enforceable, that have clear metrics, that have transparency. There are supposedly accountability requirements in the Canada Health Act, but those are basically self-reporting, and they've been very rarely enforced. So we need much more robust ones, and they need to be robust from the beginning, and they can't rely on optional self-reporting and only the occasional enforcement when things get so egregious that the health minister can no longer look the other way.
I agree with everything Chris just said, but I would add that I'm worried that this emphasis on negotiation, because as Chris also said earlier, the provinces just keep saying, give us the money. We have given them, the federal government has given them all kinds of money for a whole lot of things. And including in my province, they haven't spent it on what they were supposed to spend it on. And in some provinces, we've seen tax cuts, but not increase in the health budget as this is going on. So I'm worried that negotiations will mean we go back to non-enforceable standards of the sort that were being described. And I think that when the provinces and territories respond by saying, what do you know about long-term care? As Lagoa said, I would say, what do you know about long-term care? You haven't been doing a good job. They're fine with the money. They just, I think they should have to say, why do you reject these standards? What is it about these standards you don't want to live with? That's the end of my rant.
It was excellent. Thanks, Pat. I think we will end there in the interest of the time. I really, really want to thank all three of you for your presentations and for answering questions. Long-term care in many ways is kind of this nexus of so many critical issues that we haven't been addressing, and you've all kind of pointed to them, right? Like yes, of course it's about seniors care, but it's also about the undervaluing of caregiving. It's about housing. It's about the gaps in public health care services. It's about not addressing the social determinants of health and investing way earlier in life and figuring out how we can build these communities. I love the visioning that Pat shared with us. And I did put in the chat the links to those books, because I think we get stuck in, asking for, our bar is low, shall we say. And so thank you for Pat, for, you're raising it to a higher standard in this report and looking elsewhere to what else we can do. I think is critical for us as a community to continue to advocate for these issues. So thank you for those standards. It's excellent that we have this principled base upon which we can do this kind of advocacy, pushing on, as Chris said, all fronts in terms of all government levels to support and make the investments that are needed for seniors in our province, but all of us, to ensure that we have collective well-being, and we can do that together. So I thank you again, and everyone, for joining us tonight. We will send out a link to the recording, although I do have to say I missed a bit of it, so apologies for that, as I'm multitasking, but some fantastic questions. Thanks everyone for your engagement. Good evening.